Hi, everyone. We are very excited to be here today talking about correctional mental health. We've also been very excited to see how many people have shown interest in this topic. What we realized that the audience is very diverse. Ashley and I are both psychologists, but we both been either working in corrections or doing research in corrections for long enough to know that the majority of mental health professionals who work in correctional settings are actually not psychologists. So there's a wide variety: psychologists, psychiatrists, social workers, counselors. And so we really mean this introduction to correctional mental health to be applicable or relevant to everyone, even if there are places here and there where we might be referring to psychology guidelines, but of course there are equivalent guidelines in other fields as well. Obviously, correctional mental health is a vast topic. We're only doing an hour and a half here, so please, this is just a very superficial overview, but we hope to touch on all of the different aspects that we believe are important for people to think about, whether you're currently working in correctional settings or thinking about going into correctional settings. And now I'm just gonna let Ashley start. Oh, finally, we've organized this into three sections. Ashley is going to start by just covering some introduction to definitional concepts and to the correctional mental health landscape. Then I'm going to be talking about clinical issues in correctional mental health, and Ashley is going to end by talking about research in correctional mental health.
To kind of expand what Virginia was talking about a minute ago, so both of us are obviously psychologists. That's our background. And so some of these initial slides are, from that lens of psychology. But, again, many of the issues and the distinctions that we're going to talk about probably have equivalent issues in other subdisciplines that are related to correctional mental health. So especially those of you who are psychologists or have some background in psychology, you might be more familiar with the term forensic psychology and wondering kind of how correctional psychology fits with forensic psychology. Is it part of it? Is it a separate issue? And there is a little bit of a complication in terms of the distinction. There's been some evolution over the years regarding how forensic and correctional psychology should and should not be distinguished. And there still is a bit of debate today as to how these two sub areas fit or don't fit together. One conceptualization is to view forensic psychology in a broader sense, that the larger umbrella starts with forensic psychology. And under this conceptualization, forensic psychology is defined as essentially any application of psychology, such as principles, theories, practice, research, consultation, whatever, to the legal system, and that it can be essentially interchangeably used with terms like psychology law. So under this kind of framework, corrections is really encompassed underneath the umbrella of forensic psychology because it is an area that is relevant to the criminal legal system. And so it is, again, under this conceptualization, a facet within forensic psychology, just like other sub areas might be, such as police and public safety psychology, victimology, what might be termed legal psychology. So all of the pretrial types of stuff that forensic psychologists are familiar with. Another way to look at it, and this is probably the more current way to look at it, is that forensic psychology are separate but related fields. And so in this conceptualization, forensic psychology is more about the application of psychological principles and research to help resolve legal, contractual, or administrative matters. On the other hand, correctional psychology is the application, again, of psychological principles or mental health principles or social work principles or whatever field you're coming from. So those principles and research specifically to the justice system to inform things like classification of individuals, treatment, management of certain offending populations, essentially to reduce risk and improve public safety. But of course, there's a lot of overlap in these two areas. Forensic psychology since we're talking about correctional psychology, we're more focused on the criminal legal aspect of things. But of course, forensic psychology can also include civil issues. That would be a clear distinction in terms of population or setting that forensic psychologists might touch on that correctional psychologists probably wouldn't, but there's some other overlapping issues, again, big relevance to criminal legal issues. They have similar historical roots. We obviously address similar populations. People who are in forensic psychiatric hospitals, for example, are often rotating in and out of hospitals and jails and prisons and other systems. We have, again, similar settings, similar educational pathways, although I'm going to talk in a slide here too about some differences in the training expectations. And certainly there's some overlapping career domains. Virginia and I both have done work related to both forensic and correctional psychology. This is just for your reference. This is an article that Tess Neal published in 2018 that gets into a bit more detail about the overlap and relationship or distinctions between these two fields. And she takes the perspective, again, that they're separate but related categories of areas of study and training and career that fall under the larger umbrella of psychology law. This is a recent book. I think this came out just a couple years ago on the roots of modern psychology law. And so again, this book essentially conceptualizes psychology law as the broader term and correctional forensic psychology as related but distinct areas. So relative to forensic psychology, there's a couple poignant quotes here on this slide. I'm not sure if it's large enough for you to be able to read it, but it's essentially pointing out the fact that relative to forensic psychology, correctional psychology has been given much less attention as far as developing it as a specialty area. And I think if you look at the second quote here, it says, no mental health professionals working in corrections had been educated or trained for the job. Most were on a steep learning curve, and frequently we did not know much about the professional or scholarly foundations of what we were doing. And I think to some extent that is true today, that a lot of people, maybe some of you are currently working in correctional environments, and you're learning that you weren't taught everything that you needed to know to be a good clinician or practitioner or researcher in this area, and that maybe some of your generalist training or even training specific to forensic psychology is not as applicable to this setting as you might have thought. But again, if your background is something other than psychology, maybe you can give some thought as to whether any of these kind of sentiments ring true in your discipline as well. So to emphasize what Tom Grisso and Stan Brodsky were talking about in that chapter, there are some pretty clear differences in the formalization of ethical expectations, for example, and again, training differences. So on the forensic psychology side, again, those of you familiar with this field know that there are specialty guidelines for forensic psychology that were published in by the American Psychological Association originally in 2013. They're currently undergoing revisions right now. But essentially, these guidelines address responsibilities pertaining to different parties within the psychology law relationship, procedures, scope of competence, and mostly it focuses on pretrial evaluation and consultation with legal participants, and a little bit on forensic therapeutic services. And then again, within forensic psychology, we often have clinical practice that requires specialized training, at least at the pre-doctoral and postdoctoral level. And then people can go as far as earning board certification through the American Board of Professional Psychology, specifically in forensic psychology. Now, if you contrast that to the correctional side, there is no real discussion of correctional psychology issues in the forensic specialty guidelines, and there really aren't any separate equivalent guidelines or recommendations for the practice of psychology, and which is kind of unfortunate because as Virginia is going to talk about in a little bit here, ethical issues can be quite a bit messier in the correctional field, and sometimes other general guidelines that we are asked to rely on in the profession don't always jive as well with the policies and procedures that we have to adhere to within the institution. And there's really no expectation on the side of correctional psychology to get specialized training at the pre and postdoctoral level. General clinical training is typically considered acceptable, although people tend to recommend that specific training is helpful and encouraged. And there's no designated ABEP certification specialty area, which kind of begs the question, we won't have time to address this, but just a food for thought is, should correctional psychology be considered a specialty area in a similar regard that forensic psychology is? So you might be thinking, what guidance do correctional psychologists actually follow? And here's kind of a list of different things that we have to rely on. And again, there may be conflicting standards for how to respond to unique scenarios that come up in correctional settings. So, for example, APA's general ethical principles of psychologists in their code of conduct, really emphasizes do no harm, but that might, some of that might not, again, bode very well in a system that is quite harmful. And some of our obligations as psychologists could be interpreted as going against some of those recommendations in the code of conduct. We also have some more specific correctional mental health guidelines. So, for example, the National Commission on Correctional Healthcare Standards for Mental Health Services in Correctional Facilities. It's a bit of a mouthful in there. As well as the American Correctional Association's performance-based expectations for adult correctional institutions. Again, these are just some examples here. The International Association of Correctional and Forensic Psychology used to have standards of practice, but those were essentially sunsetted in 2019 in favor of these other two guidelines. And of course, we have state and federal policies. Policies are specific to the institution, sometimes requirements resulting from a civil litigation. So when correctional agencies get sued and then they have to make changes based on the court ruling and consent decrees and things like that. And then we also have, a number of academic and practitioner-focused publications. One great example is a publication led by Virginia on assessment and treatment specifically in jails. So at this point, I'm going to turn it back over to Virginia to talk a little bit about the systems of incarceration and other, ways in which we detain folks in the United States.
Great. So when we think about correctional mental health, we are thinking about any application of sort of clinical practice in a correctional setting. And of course, in the United States, there are several different systems of incarceration, and those differences have actually implications for clinical practice. Probably the most important distinction is the distinction between jails and prisons. And I'm sure that everyone here in the audience understands the difference, but I just want to get a little bit more into the implications for clinical practice. So jails are locally operated and mostly house individuals awaiting case disposition. Prisons, on the other hand, are operated by the state and house individuals who have already been convicted. So some jails might house individuals who've been convicted on low-level charges like misdemeanors. So they're doing just a few months, they're serving their sentence in the jails. But for the most part, people who are in jails are technically innocent, right? Their cases have not been decided yet. Now, in terms of relevance to clinical practice, probably the most important distinction is that when you work in a jail, you never know how many people are going to be admitted or discharged on any given day, right? Because your admissions depend on how many people are arrested, and people can be discharged. There are a lot of unplanned discharges, and that might be because people are bailed out, sometimes during off hours, or they go to court and they get released, or those are the two main ways in which people are released. And sometimes you might have a little bit of a heads up, again, if you're working with people who are sentenced on a misdemeanor, or if you're in touch with a lawyer and you have a sense that they might be entering into a plea the next court date. But those of you who work in jails know that very, very often you just don't know when your patients are going to, or your clients are going to be coming in or coming out. That makes it very difficult to plan for leadership or administration, even to think about how many people do I need to have on the intake jail doing intakes on any given shift. I was recently visiting a jail in California, and we were observing intakes, and on one day there was just one person, and we were told that on the prior day there were over 100 people who were intake during the same shift, right? So you can go from 100 to 1. I mean, that is a little extreme, but it's very variable. And then, of course, when you are doing treatment with people, it makes it difficult to plan in terms of long-term care and what are your goals for treatment when you don't know when people are going to be getting out. That is very different in prisons. So in prisons, for the most part, the people are being admitted from jails, and in systems that function well, you will have some information about the person who just got convicted and sentenced and is heading over to your prison, right? So you have a good sense of who is coming at any given time. And typically you have some information about that person because they're not coming from the streets. If they have a mental illness, they probably have already been taking medications in the jails. They have a diagnosis. So you have some information about that person. And of course, you know when they are getting out because everyone has a discharge date, and that makes it much easier to plan for re-entry, to really start getting ready for re-entry and addressing those criminogenic factors that we know are so important when people are re-entering back to the community. The other thing I want to say about jails is that people come directly from the community. So frequently that's a transient population. People have a lot of legal uncertainty. Many people are intoxicated when they come into the jail or experiencing acute symptoms. And so this is why jails are much more chaotic than prisons in terms of your ability to really clinically provide care, and also why we see that even though the population is very similar, but the clinical acuity is higher in jails, and that contributes to why we see rates of suicide that are significantly higher in jails than in prisons. In addition to the distinction between jails and prisons, there are, of course, jurisdiction levels. I'll go through this pretty quickly, but you can be in the state system if you've committed state crimes. These are managed by local and state governments, and so you have county jails and state prisons that have different security levels. Then you have the federal system, which is completely separate, and that's for individuals who commit federal crimes. It's managed by the federal government. Also, they have jails and prisons. Then there is the military correctional system. And I want to say I'm very unfamiliar with the military correctional system. I know people who work in that system, but I've never done any direct work. But there are 59 domestic facilities and 11 overseas facilities, and this is managed by the Department of Defense. The next system I want to very quickly touch on, because I think that sometimes we forget about this system of incarceration, is immigration system. And part of why we tend to forget about it is because it is actually considered a civil form of detention, but it looks exactly like any other form of detention within the criminal legal system. So the immigration detention system is the practice of holding in custody people or families who are subject to immigration control, either while they're waiting permission to enter or prior to deportation. And it has two purposes: is to prevent non-citizens from absconding deportation when people are facing removal, that's the sort of legal term, to their countries of origin, and also to protect the public. I want to emphasize that immigration detention is the only form of detention where you don't have the right to having an attorney. So you can be detained in facilities that look very much like jails without having the right to counsel. And there are different types of facilities. So there are federal immigration detention centers that are managed by Immigration and Customs Enforcement. There are a number of privately controlled correctional facilities. And then also state and municipal jails sometimes subcontract bed space to ICE. So you will have a local jail that houses people who are involved in the criminal legal system who've committed crimes. And then they sort of rent out a part of that jail or some of those beds to ICE so that they can also detain non-citizens. And those people are not mixed up, but they are within the same institution. There are currently about 34,000 people in immigration detention, and I think mean, unlike other forms of detention, there is less oversight. And so we don't know much about what's happening. We don't have statistics about how many people exactly have serious mental illness in immigration detention. The use of restrictive housing, suicide rates is much more difficult to get data about all of those issues in immigration detention. I also wanted to tell you very quickly about some relevant case law. So Ashley was talking before about different sort of guidelines that when you're working inside of a correctional setting, you want to be familiar with. And as we said before, we talked about guidelines for psychologists, but I know because I've worked with many counselors and social workers and psychiatrists that there are also equivalent ethics, an equivalent ethics code for all of those different disciplines. I think everyone from all different disciplines would agree that typically those guidelines are not enough to guide us through the very challenging ethical issues that you face inside of correctional settings. And part of why I think we all feel so lacking in guidance is because the courts itself, they have not really set forth very clear standards as to what is ethical practice or inside of correctional settings. And so there are more cases than these, but I just want to very quickly walk you through what I think are the most relevant cases when it comes to setting standards for correctional practice. And of course, the first one was the US Supreme Court case in 76, Stell versus Gamble. So this is when the courts basically said, if you show deliberate indifference to injury, referring really to medical injury or of someone incarcerated, then that is considered a violation of the Eighth Amendment. And I just want to emphasize how much of a low bar deliberate indifference is, right? It means that you are aware that someone has a medical condition and you choose to ignore it. So that is the standard that was set forth in 1976. Then a year later in Barber v. Godwin, those rights were extended to those with psychiatric conditions. So Stell versus Gamble really talked about medical conditions, and then those rights were extended to people with psychiatric issues. In 1979, those rights were extended for those in pretrial detention. So the two cases prior really talked about people who had been convicted, and then Velby Goldfish extended those rights to jails. Reed v. Stell is the only case that has really set forth some minimal standards for what's considered adequate mental health care. And it's actually not a Supreme Court case, so it's a court in Texas. And in this case, there are 6 minimal standards. And if you really learn about them, you realize, again, that we are talking about a very low bar. So it basically talks about how you need to have a way for identifying people who have mental health issues, that you need to offer treatment that it's more than just housing them all together or segregating them, that you need to have mental health professionals who are trained and in sufficient numbers, and that you need to have some sort of suicide prevention program. But even though it's still a low bar, at least it more explicitly talks about, at a minimum, what services do you need to be providing inside of correctional settings. And then lastly, this Yomber v. Romeo case in 1982 makes it very clear that the courts give a lot of discretion to mental health professionals, which I think it's a good and a bad thing. So it's a good thing because, of course, our clinical judgment should be considered. And on the other hand, the language in this case makes it very hard to point to decisions by clinicians that maybe were significantly wrong. And so the case basically says the decision, if made by a professional, is presumptively valid, and it has to be I forgot the language exactly. I think it talks about it has to be a substantial departure from accepted clinical judgment to be considered a liable decision. And so really, when you look at the legal standards, you realize that the courts have set a very low bar in terms of what's ethical clinical practice and what are minimum requirements, and they defer almost entirely to the mental health field to set those standards, which is why I think we all, as a field of mental health, have such responsibility to really start documenting and talking and developing guidelines to set up standards that are ethical.
Okay, so I'm going to talk a little bit just to give you a snapshot of who's behind bars. And again, if you're already working in these settings, you probably have a pretty good idea of what the population looks like. This is a graph that was pulled together by the Prison Policy Initiative, and I think these data are based primarily on information from the Bureau of Justice Statistics, and there's a lot going on in this particular graph, but it essentially shows you a pretty detailed breakdown of how many people are locked up in the United States, where they're locked up, and for what reasons. Again, you probably can't see it. I'm sure it's a little small on your screen, but around the different parts of the diagram, you can see some of the reasons, the offense types that people are detained for. So the larger circle, you can see that most individuals are incarcerated in state prisons, followed by local jails, and then federally operated prisons and jails. And then the kind of like curved bar on the right-hand side looks at some of those more specialty or non-traditional forms of detention and incarceration. So youth detention facilities, territorial prisons, again, immigration detention. It lists involuntary commitment, and then the thinner bars on the bottom are tribal detention centers, which is not something that we talked a lot about explicitly, and then people in military prisons. This is coming directly from a report from the Bureau of Justice Statistics, and this is the latest demographic breakdown of people in jails specifically. So I won't, again, go through every data point on this table, but you can see that obviously there's a higher proportion of men incarcerated relative to women. I think it's interesting to look at the number of juveniles detained as adults. So 0.3% of people incarcerated in jails are young people who are being held as adults, which is, as somebody now living in Australia, is not something that other countries tend to do. And then there you can see the racial breakdown. The majority of people incarcerated in jails across the country are white, but obviously that represents a different proportion of people relative to the number of people in the general population. This is a graph from the Vera Institute of Justice. Again, looking at the jail population, Virginia talked about kind of the more chaotic setting of jails relative to prisons. And one of the reasons why it tends to be a little bit more chaotic, aside from a lot of the acute issues, is that most people in jail are actually awaiting trial. So again, something that's kind of unique to the US is that we put people in jail who are we have basically two types of populations within a jail setting. We have people who have not yet been convicted of an offense and they're awaiting trial. And then we have people who are convicted and serving time for lower level offenses, or maybe people who violated probation and are now spending the rest of their sentence in jail. And so this just shows you that there's a significantly larger proportion of people who are awaiting trial and still dealing with many of those legal issues, which is sometimes what's contributing to the fact that it's unpredictable as far as when people are going to be released or when they're brought in. In terms of prisons, this again is a table pulled from a report from the Bureau of Justice Statistics, and you can kind of see the, again, breakdown here. This is set up a little bit differently. It's looking at federal versus state individuals incarcerated, men versus women, and then several different racial and ethnic groups broken down. And just to kind of highlight this racial and ethnic disparity that we know exists within the correctional system, this is a graph that I pulled together based on data from the US Census and data from both of those BJS reports that I mentioned a minute ago, the one on jails and the one on prisons. And so you can kind of see here that, for example, relative to the number of Black individuals in the general US population. We incarcerated a significantly larger proportion of that population, both in jails and prisons, relative to the population of white individuals. And that disparity is a little bit smaller when it comes to Hispanic individuals versus white individuals, but we can still see that difference in the number of people incarcerated who are people of color versus their representation in the general population. And again, this is probably no surprise, that there's this higher proportion of people that we incarcerate who are Black and brown relative to their representation in the general population. Mental illness is also something that is obviously of higher prevalence within jail, particularly jails, but also prisons relative to the general population. So again, this is a figure coming from the Bureau of Justice Statistics. This is, I think, even though this is from 2011 to 2012, this is I believe, the most recent summary of data trying to capture the prevalence rates of serious psychological distress. And they've broken it down again in terms of serious psychological distress versus a history of a mental health problem versus no indication of a mental health problem. And so you can see the comparison between jailed individuals versus people in prison. And again, to echo Virginia's sentiment earlier, there's a much larger proportion of individuals in jails with serious psychological distress. That difference becomes a bit smaller when you're just talking about a general history of mental health problems. But again, that just sort of highlights that we do have quite a few people who are experiencing mental health issues within our correctional systems, which is sort of the reason why we're talking about this topic here. I wanted to very briefly just reiterate the fact that mental illness has a relatively weak relationship to crime. Again, those of you familiar with this field probably are aware of some of the myths and conceptions about the link between mental illness and dangerousness, or mental illness as a predictor of criminal behavior. And it's really just not upheld in the literature. So certainly for many individuals, mental health is an issue that needs to be addressed. But we do know that mental illness, again, is not a major predictor of criminal behavior. And 90% of people with serious mental illness who are justice involved do so for reasons other than their illness. We know that people with SMI are more often victims of crime than perpetrators. And really just a small percentage of people with SMI end up behaving in very violent types of ways. So just want to kind of keep that in mind, that even though we have a larger proportion of people with mental illness, it still is a relatively weak relationship between mental illness and criminal behavior or dangerousness. Incarcerated folks are also disproportionately poorer. They tend to be less educated. They tend to have more chronic physical health problems, infectious diseases. There's a larger proportion of people with intellectual or cognitive impairment, and especially in prisons, we have an aging prisoner population. So these are all things to kind of keep in mind as you're thinking about working with this population. They're very high needs, and that might translate to a lot of different treatment modifications or considerations when working with individuals who, again, meet some of these criteria. Hopefully, because some of you are thinking about working in corrections, maybe you're not quite in the field yet, but you're a student or you're training, or maybe you're thinking about switching career paths. We wanted to highlight a few things about who's working in corrections. And Virginia talked before about the fact that, most mental health professionals within correctional facilities or community corrections even are not licensed psychologists like we are. Many folks have other kinds of backgrounds like psychology, psychiatry, social work, counseling, mental health nursing. And a lot of mental health clinicians don't receive training, as we talked about before, in correctional or even forensic psychology. A lot of times that generalist training that we get is considered sufficient. Then we learn on the job the ways in which we need to modify our practice or how we're approaching individuals. And there's a couple studies on here also just talking about the fact that corrections departments have a lot of difficulty recruiting qualified mental health professionals. So the one cited at the top, an estimated 85% of correctional departments said they had difficulty, and 70% reported difficulty in retaining those competent behavioral health staff. So they not only have problems with recruitment, but they also tend to have problems with retention as well. And again, a lot of times our training doesn't quite prepare us well enough to work within these settings. This is another, just for your reference, this one's specifically within the context of correctional psychiatry, but I think this is a good article that came out just a few years ago that sort of addresses some of the misconceptions about working in corrections as a mental health practitioner. Some of these misconceptions you might hold yourself, but this is an interesting read if you're considering joining this field and are a little bit worried or kind of hesitant about doing it. I think this is a great article that addresses some of those issues, or hopefully will help mitigate any concerns that you might have about working in this area. Okay, so I'm going to turn it back over to Virginia to talk a bit about clinical care issues within correctional mental health.
All right, so these are what we've identified as being the core areas of correctional mental health care. We're obviously not going to be able to go in detail through all of them. I am going to talk a little bit about some of them, but just very quickly, starting with booking, screening, and assessment, right? So being able to identify people as they come into the facility who might require treatment is very important. So doing those quick screenings initially and then more full assessments later on is a very important part of correctional clinical care. The second part is providing treatment, and I'll talk briefly about how the goals of treatment might be a little bit different, as I've sort of alluded to, if you work in a jail versus a prison, and some of the levels of care that correctional systems typically offer, although this varies across systems. Suicide prevention is key inside of correctional facilities because, as you might know, the rates of suicide are significantly higher in correctional institutions than in the general population, and this is particularly so in jails. We have also seen in recent years an increase in deaths by drug overdose inside of correctional settings, and so this is an area that now has become also a core area. It's obviously very relevant to medicine departments, but it's also very relevant to mental health departments. So I'll talk about it very briefly. Assessment and treatment of people in restrictive housing is also something that probably mental health professionals will say is not their favorite part of the work that they do, but it's something that if you work inside of correctional settings, you will be exposed to. And we're not going to get into this today, but I will just say that these are there are different terms that are used to really refer to what is a practice of removing individuals from the general population and isolating them for most of the day. So typically this is about 22 to 23 hours a day where individuals only get an hour or two out of cell for some form of recreation. Again, this varies. So there are facilities who are offering people 3 or 4 hours out. Individuals typically get 3 showers a week. And of course, the conditions of confinement are very different. So some institutions that I visited, the cells are very dark and don't have windows. In other institutions, they're a little bit better. And then finally, there are many different reasons why individuals end up being segregated. So you might have heard the term disciplinary housing or punitive segregation. So this is when individuals violate some of the institutional rules and are sent to segregation as a form of punishment. When that happens, they know how many days they are getting in that type of segregation, so they know when they're getting out. A very different form of segregation is what's typically referred as administrative housing, and this is when it's sort of a measure when the security department has identified people who they believe might be violent in the future, and then they put them in administrative housing or segregation as a sort of a way to prevent that violence from happening. And people can end up in that form of segregation for very long periods of time because there is no sentence to it. Now, mental health professionals are involved in this practice in different ways. Sometimes you might be the security department might come to you and say, this person just violated a rule. Are they okay to go to segregation? And then also sometimes you end up providing treatment to people who are in segregation. The next core area is reviewing deaths, or what's also called morbidity and mortality. And this is typically spoken about in the context of suicide prevention. So reviewing cases of people who've died by suicide. But I believe that it's very important to do these reviews for all sort of deaths that involve people who have mental health issues, whether they are a suicide or a medical death, and also for adverse events, even if they don't result in death, right? So very serious suicide attempts, very serious act of violence. I think that systems learn a lot if you actually have an honest and transparent meeting where you discuss what led to the event and identify anything that the system could have done differently. Next, it's continuous quality assurance. So in order for mental health departments to really be efficient and to improve their practice, there needs to be solid QA departments that are looking at data and are looking, and as I said, the death reviews should also be part of this QA process. And then finally, another core area is reentry, is how it's working with people who are reentering back or being discharged back into the community and getting them ready for that, right? What are the services that you need to put together? What, if you work in a jail, what type of work do you do with diversion programs, ATI providers to coordinate those releases? That is another really important area of correctional healthcare that we're not really going to get into today. I wanted very quickly to talk a little bit about multicultural considerations. And obviously, this one slide does not do justice to how important I think this issue is. But I just will say that when you are working in really in correctional systems across the world, right? But certainly in American correctional systems, you need to have an understanding of the societal forces that shape the American criminal legal system, and the culture and the experiences of those individuals who are incarcerated. So when you work in correctional systems, as Ashley was saying before, you are going to work with a lot of people of color and with a lot of people that are culturally diverse, not just in terms of race, ethnicity, but also in terms of gender identity, sexual orientation, country of origin, spirituality, religion. And many of them, probably the vast majority of them, are going to be very different from who you are culturally, right? And so that means that we need to really be thinking about that. And there are different terms that are used to really refer to what it's like to be culturally competent in your clinical practice: multiculturalism, cultural responsiveness, cultural humility, which really refers to how you have to think not only about the culture of the person in front of you, but also how your own culture makes it so that you might be biased or have preconceived ideas about the person in front of you. And that is going to affect how you clinically formulate the case as well. And then, of course, what in the field of medicine and psychiatry, they refer to more as a structural competency, which is incorporating an understanding of systemic barriers, bias and discrimination, systemic racism, when considering the psychological experiences of patients who are in the system. And then finally, considering the jail and the prison culture, right? I very often see how clinicians and I've done this myself, right? When I worked in a jail for 8 years, but now that I consult with other systems and I review medical records, and we are sometimes very quick to write things like patient is manipulating or is doing something for external, secondary gain, and we tend to sometimes forget that some of those behaviors might not really be manipulation in the way in which we understand manipulation, but really a way to adapt to an environment that it's really difficult to adapt to, an environment that really is a different culture, that has different rules. And so all of that needs to be fully incorporated into the work inside of correctional settings. Just very quickly, again, I won't get into a lot of detail about each of these core areas, but screening and assessment, jails and prisons need to implement robust approaches to mental health screening and assessment, and that includes early identification, so especially in jails when people come into the jail. And those screenings tend to be really fast in jails because, again, you're just having, especially in large urban jails, the number of people who are coming through your intake might be really large. I mentioned today the differences between prison and jail. So in prisons, there are about 600,000 people that are admitted to prisons every year. In jails, that number is over 10 million, right? So the rate at which people are admitted into jails is very high and very rapid. And so you want to put together some quick screenings to identify people for whom you then need to do an ongoing or a more thorough assessment. But you also need mechanisms to be able to identify people on an ongoing basis, right? Because sometimes people might have a lot of reasons why they decide not to talk about their histories when they first come into the jail. People are highly stressed. They've just been arrested. Again, different in prison where you hopefully are getting some information about the person. But in jails, that might be difficult. And so you might not, that individual might not screen in, right? They don't answer yes to any of your questions. You don't have any information that they've received treatment in the past. And so then you might just decide that they don't need to receive mental health treatment during that incarceration. And then later on, they might start endorsing symptoms. They might decide that they want to ask for help, or some people might go through a first episode while they're incarcerated. And so you want to have mechanisms through which people can self-refer, or the Department of Corrections or Sheriff's Department can refer people to the mental health department. Families, court players, sometimes defense attorneys spend time with their client and they realize that something is not right. So having very clear mechanisms through which those parties can really relate information to the mental health department to trigger a referral for an assessment. And of course, there are different goals for screening and assessment. A very important goal is suicide prevention, so suicide risk assessment, identification of goals for treatment, and then also identification of areas that you need to be thinking about to inform reentry. And sometimes in some jails and prisons, there are some policies that actually exclude certain diagnoses from being eligible. So individuals with certain diagnoses for being placed in segregation. So you might be doing an evaluation, and this is, I think, ethically complicated, but you might be asked to do an evaluation to determine whether there are contraindications or any diagnosis that should divert people away from segregation. Also, very quickly, I also want to mention that jails and prisons are very difficult places to come up with accurate diagnosis. So there is a significant problem with misdiagnosis inside of correctional settings, and this is both in the way of overdiagnosing and also underdiagnosing. And this is due to a number of different issues. One is that sometimes you don't have enough time to do that assessment. You might have inconsistent records. So if you are reviewing records of people who come into the jail, if you have access to community records, often people have a lot of ER visits with a lot of different diagnoses. Many people are homeless, so you don't even know whether what their diagnoses were previously. Then there is the issue of people coming into systems who are intoxicated or who are going through withdrawal. And then, of course, not surprise to anyone, at least not to anyone who is working in correctional settings, there are drugs inside of jails and prisons. And so some people can get intoxicated even if they've been in the correctional setting for some period of time. And of course, all of those sort of substance-induced symptoms might make it difficult to come up with the right diagnosis. The stress of incarceration, being in an environment that is very anxiety and stress inducing, can really make people look like they have an underlying mental illness when they really don't. I briefly mentioned the issue of cultural racial biases. And then, of course, the fact that there are motivations for people to both exaggerate, whether that's as a way to, as I said, to really adapt to the environment, and also to minimize symptoms. So some people are afraid of being victimized by other people who are incarcerated and might decide not to they don't want to take medications because they don't want to feel drowsy. This is typically the case when people really think of the environment as dangerous and they really want to be alert and hypervigilant. So they might decide not to disclose their histories because they don't want to be medicated. So there are many reasons inside of these settings that make people want to present in a certain way, which can also complicate clinical presentations. I'm going to skip through this because I already talked about this very quickly before. I will just say that sometimes, and depending on the resources that you have, the goals of treatment might be different in jails versus prisons. So jails tend to focus more on just symptom management, suicide prevention, minimizing stress, especially reminder that people are going back and forth to court and learning about their cases, which can be very stressful, safety maintenance, crisis management. And if you have enough resources, you might be able to do some real work, rehabilitation work. But in many jails around this country, those resources are not there. So you're really just focusing on crisis management. Prisons have much more of an opportunity to provide long-term, to develop or set long-term therapeutic goals, to do more skill training, and certainly to do rehabilitation, meaning sort of thinking about recidivism reduction. When you think about treatment, mental health treatment inside of correctional settings, there is very limited research. So most of what we have is theoretical commentary and not empirical research. Most research out there has focused on prison, so there is much more on prison than jails, but even prison research is limited, and it has focused primarily on recidivism as an outcome. Now, there are some things briefly that we've learned from, I guess, two main things that we've learned from the research, the limited research available. One is that suggests that cognitive behavioral interventions and mindfulness-based interventions might be effective. And also that treatment that focuses on rewards versus punishment is preferred. And then also that we do know that there are some interventions that are not supported by the research. And these are programs that emphasize control or coercion and that are more sort of like boot camp type of programs. When it comes to treatment, as I briefly mentioned before, there are different levels of care that, and for the most part, institutions will have general population. So you might have people who have mental health issues, but they can live fine in general population, meaning with other individuals who don't have mental health issues, and they will be then brought into a clinic or seen by a counselor maybe once a month or more frequently than that. So that will be sort of the equivalent to outpatient level of care in the community. Then most institutions have some form of residential housing where they cohort everyone who has mental health issues. And these might be people who have a very serious mental illness and are very symptomatic, but also people who maybe are not as symptomatic, might have anxiety disorders, trauma-related disorders, but who really struggle living in general population. And then, of course, and this is an issue in jails across the country and also to a certain extent in prisons, but all correctional settings should have access to inpatient level of care, whether it is inside of they might have a unit that it's licensed to provide inpatient level of care or send people out to county hospitals to receive inpatient level of care, and then 24/7 crisis emergency intervention treatment. I've mentioned this before, but the rates of suicide is the leading cause of death in jails around the country. And when you think about the suicide rate in the US population, it's about 14 per 100,000 people. That is much higher in prisons, and in jails is actually about anywhere between 43 and 45 per 100,000 people. So it's a very significant jump. These are the components that are absolutely necessary of all suicide prevention programs inside of correctional settings. You can sort of go through them and read them. One thing I just want to say about suicide prevention is that I think because of the very real concerns that we all have about people in correctional settings committing suicide, we have moved to implementing some suicide prevention measures that are actually very anti-therapeutic. And I just want to sort of throw that out there, food for thought if you're working in a correctional setting. And these include, for example, removing people from the general population, isolating people in what some places called safety cells or suicide watch cells, where they are removed of all of their belongings. They are removed from the company of their peers. And so, yes, in that, and I get it. I've been an administrator in a jail. I get how difficult it is to balance what's therapeutic versus, the liability or just saving lives. So it is a complicated issue. But I think that as a mental health profession, we need to do a better job at really thinking about what suicide prevention programs work and which ones are really anti-therapeutic. And in some ways, also kind of dehumanizing. Some of the suicide gowns that some institutions use can be pretty rough and dehumanizing to some people. So that's just some food for thought on suicide prevention. The next is overdose prevention and management, which is something that we have really started to think about more in recent years as the number of fatal drug overdoses are increasing. And so some of the things that are important about this is that mental health professionals really need to be well trained on identifying symptoms of, when people are detoxing, when people are experiencing acute withdrawal symptoms or severe progressive intoxication, to really be able to identify those symptoms. Sometimes mental health professionals do not receive proper training on these. And then, of course, administration of naloxone intranasally for everyone, including the security staff, identifying individuals who are at risk of overdose during the initial screening and assessment, any medication interventions for opioid drug use or medication-assisted treatment that are implemented in jails and prisons can be incredibly helpful to prevent overdoses. And then, of course, proper communication between healthcare and security staff and proper emergency response protocols. The last thing I want to cover when it comes to clinical care inside of correctional settings is the issue of ethical issues. And we've touched on this a few times, but the more that I do work inside of correctional settings, the more I realize just how ethically compromised we all are when working in these settings. And part of it is because jails and prisons are environments where we can do a lot of work that it's incredibly helpful to people, but they also can be environments that are very harmful to people. And so if you work inside of a correctional institution, I mean, sometimes you'll see your jail or your prison on the news on a regular basis. I worked on Rikers Island, the New York City jail system, and that jail was in the New York Times every other day, and not for good reasons, right? So it's typically because, there are increased numbers of people who are dying. Here are just some examples, increased numbers of fatalities in the LA County jails, in the New York City jails, in some prisons, women giving birth in cells or cuffed to a bed. I mean, there's so many of these that you are constantly reading about. And so this makes it so that I think we need to acknowledge that we work in environments that by nature can be very harmful to people. So that is important because when you work in coercive environments, right? Coerced environments increase the chances of human and civil rights violations, and therefore increase the chances of us mental health professionals facing ethical and moral challenges. And so I think that we all have a human rights responsibility when we work inside of correctional settings, and this has been defined as being alert to and report any practices that are harmful to incarcerated people. Now, of course, this is very difficult if you don't work under an administration that really helps you, protects you, and provides sort of ways for you to be able to do this. And of course, it's difficult because everyone working in correctional setting faces the issue of dual loyalty, which is this split alliance between the therapeutic and the security goals, right? So thinking about, is this practice really therapeutic and in the best interest of the person in front of me, or am I doing this because I want to appease the Department of Corrections, the officer? And that is just a tension that you're constantly navigating when you're working in those institutions. So it might be difficult for you to report an officer who just did something really bad to your patient, because that is the same officer that is supposed to keep you safe, right? And so I think that there are many ethical and moral challenges when you work inside of correctional settings. I'm not going to get into it, but I think these are particularly acute when you work with people who are in segregation. Some people spend months, years in segregation. This is a practice, right? Keeping people in segregation for years is a practice that other countries consider torture. And so these are things that makes it so that you have to really be thinking about these issues and reporting these issues when appropriate. I want to also refer you to this article. It's very interesting to me how there were several articles published in the late 80s and early 90s about ethical and professional conflicts in correctional psychology and correctional mental health that were so interesting. So I encourage you to read this article because it's very relevant even today. Um, it's very surprising how in the last 2 decades, there is very limited literature on the ethical challenges of correctional healthcare. Hopefully we can all change these, but I think that if there's just one thing that I want to leave you with is that it is inevitable when you work in a correctional setting for a long period of time to become desensitized to some of these issues. And so to be able to constantly remind yourself that the environment is coercive, it can be dehumanizing and desensitizing, and to be really thinking about the decisions that you make and whether they are solid in terms of ethical grounds. And I, again, even when the people that I've worked with who clearly were doing things that were not that were unethical, it was never on purpose, because in my experience, most people who work in correctional settings are there for the right reasons, right? So this is not something that you do necessarily at a conscious level.
Thank you. And I just to kind of reiterate this article, this was like Virginia said, a lot of these discussions were occurring in the 80s, and this particular article was published in 1994. And it does a really good job of outlining very specific, what if this happens, and kind of going through, here's what the APA guidelines say, but here's where, that doesn't really line up with what the policies of the institution. So it does give a lot of real world examples, but it's interesting because this is kind of the most recent article, at least that I've come across, that specifically talks through a couple ethical issues and professional conflicts. And we still really, this is 1994, now we're in 2024, and we still don't have a lot of guidance on how to resolve these ethical issues. So even though a lot of these things have been talked about, we haven't made much progress. We're still kind of in the same sort of place that we were back when this article was published. So we don't have too much time left, but I did want to spend just a couple minutes to orient you to the risk needs responsivity model, because especially if you're working in prisons or even community corrections, if you're working in a diversion court system or probation or parole, you're probably going to hear about the risk needs responsivity model. And this is the predominant model. It's not without its critics, but it's the most researched and analyzed and discussed model for reducing recidivism. So again, obviously a lot of those acute mental health and psychiatric needs have to be addressed first before people can actually engage in interventions to reduce their recidivism or reoffending. And sometimes you don't have time to do that. Again, in the jail setting, this can be particularly difficult unless people are there for a little while. But again, if you're working in those settings that focus mostly on recidivism reduction programming, you're going to probably hear about the R&R model. So very briefly, the R&R model is based on the work of Don Andrews and James Bonda, who are Canadian psychologists, and it focuses on these three principles: risk, need, responsivity. So the risk factor is essentially pointing to scientifically backed factors that predict crime or indicate the intensity of services. So the more risk factors you have, the more intensive or long-term services that you would need. And typically risks are identified through some kind of assessment tool. I've got a couple listed here, like the level of service case management inventory or the Ohio risk assessment system. And those risk factors can be either static or dynamic, meaning they're either changeable, static, or the other way around. They're either changeable, dynamic, or they're not particularly changeable, static. And again, those static factors just speak to how much intervention needs to take place. The dynamic factors are considered criminogenic needs. So again, those are the changeable factors that we identify through assessment, and then those factors form the basis of treatment planning with individuals. And the final principle is responsivity, which is a little bit more nebulous, I would say. And that's the principle that accounts for a lot of those acute issues that Virginia was talking about before. So responsivity is that, essentially delivery has to fit the way the individuals learn or process information. There's been some expansions of the definition of responsivity over time, but essentially we need to kind of account for those things in order for people to be able to engage in interventions designed to reduce their criminogenic risk. These are what they call the central 8 risk factors, and these have been identified primarily through the literature, and you might see them referred to different things. There might be labeled differently depending on what research you're looking at, but generally these are the primary 8 risk factors that have the highest predictive power in terms of predicting offending behavior. And then these 4 in particular are what they call the big 4. So these are of the central 8, these are the most predictive. And again, this research tends to be based on normed a population. It's what we call nomothetic types of data. So when you're working with individual people, their individual risk factors may be more or less prominent. But when we look at offending populations as a whole, these are the 8 risk factors that tend to stick out the most, with, again, these 4 at the top: criminal history. Again, just to have an illustrative point, somebody who's who has a first-time offense is going to be lower risk than somebody who's been, quote unquote, career criminal over time. Again, the needs principle, these are these changeable factors from the central 8 that are used to inform the targets of treatment. And again, the more needs somebody has, the higher intensity those treatment programs need to be. So that means they need to be longer term, they need to be more intensive, more individual, and often group interventions are common to address the needs principle. As I said, the responsivity principle is generally about the delivery of services and the match between those services and that individual's skills or abilities, to process, even access information. Again, that definition is sort of expanded over time. And it might include things like the person's reading or writing skills, their cognitive or learning abilities, right? If you have content that is written at a 8th grade reading level and the person only, has a 3rd grade reading level, they're not going to be able to engage in those services. It might also include things like language or other cultural issues. Again, mental health symptoms, right? If somebody is acutely psychotic or seriously depressed, or even if they have symptoms of ADHD that prevent them from, participating in group or paying enough attention to do their homework assignments, they're not going to engage fully in criminogenic types of interventions. Trauma exposure has also been identified as a responsivity factor. Medical or even physical health problems, again, other acute vulnerabilities like immediate safety, right? Think of like Maslow's hierarchy of needs. If somebody is unsafe or they're unhoused, those are things that you're going to have to take care of or help that person address before they can actually engage in recidivism reduction types of programs. And then there's also been some discussion about something called systemic responsivity, where we consider whether the system itself is capable of delivering the types of interventions that that person would need, or other kinds of environmental considerations. Again, Virginia talked about how, correctional systems are inherently not the most therapeutic environments, but how can we sort of make the environment as therapeutic as possible, so that people can engage in the programmings that we know will help reduce their likelihood of reoffending. And the responsivity principle is very important, because even the most effective interventions are going to fall short if those responsivity needs are ignored. Very quickly, there's been quite a bit of research, as I said, on the R&R model and whether it actually works to reduce recidivism. And I'm just going to highlight one article in particular that compared the rates of recidivism and the estimated costs of traditional punishment relative to interventions that did not follow the R&R model or did not adhere to R&R, and then interventions within correctional institutions that were informed by the R&R principles. And so this is a little bit of a complicated chart here, but essentially what you can see in the green is the cost. Okay, so even though traditional punishment, basically incarceration without any real intervention, costs less money, whereas the R&R, the non-R&R and the R&R informed programs cost a similar amount. In fact, the non-R&R programs were more costly, but overall they were relatively similar, no statistical significant differences in terms of the cost. But then when you look at the blue bars here, this is showing recidivism reduction. And so the punishment, incarceration by itself, increased recidivism by about 7%. And the non-R&R programs also increased recidivism by a similar amount, whereas the R&R informed programs actually decreased recidivism by up to 30%. So even though if you're going to, basically what this chart is saying is if you're going to do programming to reduce recidivism, you're going to get the biggest bang for your buck if you go with the R&R types of principles. And this is just the article that that chart is coming from. I wanted to end this section just by talking about a few interventions that are intended to reduce reoffending that don't work. So correctional quackery refers to essentially the implementation of correctional interventions that seem logical based on common sense, that we think they should work, but they are in fact not very supported or don't have much support at all from the research, and in fact might lead to iatrogenic effects. So the term correctional quackery, I believe, was coined by Paul Gendreau, another psychologist from Canada. And so a couple of things that have not shown much effectiveness are things like boot camps or military style programs. There isn't a lot of support for programs like victim empathy, especially for people with sexual offense. We also know that just relying strictly on deterrence or just mere containment of behavior is not particularly effective in reducing misconduct or reoffense behavior. But I do want to note that there's kind of a fine line between quackery and novelty. So just because something is a newer intervention and doesn't yet have a lot of research support because it's newer, doesn't necessarily mean that it's quackery. I think you can kind of distinguish that or start to distinguish that by whether the new interventions actually follow best practices and what we know actually works, such as following the principles of the R&R model. Okay, with the few minutes that I have left, I want to get into a few points about research in correctional mental health. If any of you out there are doing research or have been involved in research, you understand the exponential challenges that you often experience in doing this kind of work. And so a couple examples of why correctional research can be challenging, and I wrote, this is just a sampling of things that you might encounter as barriers. One, there's higher ethical standards to ensure proper protections, which that's a good thing, but there's a saying that incarcerated populations end up being overprotected and understudied because often those ethical standards are misunderstood or they're misapplied, and that, or maybe they're presented in the guise of protection, but they're really trying to protect the institution from data being revealed about their policies or practice. We experience things like significant issues with trust, needing to build those relationships. Virginia is more of the clinician of our duo, and I'm more of the researcher of the duo. And, I can tell you from my own experience, it's taken up to 3 years to just get these connections going and get some agreement and buy-in to do any research in this area. Oftentimes, departments don't view research as a priority, right? It might even be considered as a threat to their current priorities. Funding might be an issue. Sometimes it's hard to come across confidential space. You probably know this just from working on the clinical side of things, that that confidentiality is required for research participation as well. Requirement of security clearance. There's all kinds of things that get in the way of correctional research. And Virginia and I, along with some other colleagues, actually did a study recently where we tried to capture the experiences of correctional researchers. This is a paper that's currently under review, so it's not out there yet. But of the 68 people we had data on, the top 3 barriers that people endorsed as always or almost always had to do with the correctional agency. So the correctional agency was, again, concerned the research would cause extra work for staff or otherwise negatively impact operations. They were concerned that they wouldn't have enough resources to carry out the project. And they were also concerned, again, that that the research wasn't really a priority and was kind of getting in the way of their operations. It was interesting because one of the things that people endorsed the least was the correctional agency's willingness to participate. So it seems that correctional agencies want to be involved in research. They just also have these other barriers that they consider to be more of a priority, and that might prevent them from engaging in research efforts. Similar to what Virginia was talking about a minute ago, people on the research side also tend to do this work because they want to make a difference and they want to have a positive impact on the people who are incarcerated. This is just a sampling of qualitative feedback that we got from participants. So, again, they expressed, a desire to do this work despite all of those barriers because they wanted to help people. They wanted to make sure that money wasn't wasted on ineffective programs. They wanted to help people have better access to mental health care. And they just saw this group as an underserved and neglected population that they wanted to, dedicate their life's work to helping. Correctional research, again, most of what we talked about was focused on the clinical side, but the research is really, really important as well. As Virginia mentioned, we don't have a lot of research in correctional settings relative to other types of mental health settings. But research is really, really important because it can tell us what is more likely to help people, and not just the clients or people that we provide services to, but it could also be about the people serving this population, like correctional officers, probation officers, you as mental health staff, what helps you do a better job in this area. And then of course it can inform recidivism reduction, like we saw with the research related to the R&R. It can help improve safety. Good research can also help support arguments for advocacy and policy change, right? If you have research to back it up, people are more likely to buy into that. And ultimately, research can help us save money over time. Even when correctional research is messy, it can be informative and helpful. This is the last slide that we have, and these are just some ideas for widening the scope of correctional mental health research. This is not an exhaustive list, but there's been a lot of discussion about better incorporating people with lived experience, so people who are formerly incarcerated, as well as correctional staff in research planning, implementation, dissemination, further expanding cultural diversity, making sure that research teams themselves are culturally diverse, looking at issues related to systemic racism or bias, for example, including measures of racial trauma, accounting for economic or educational disadvantage, and when we're evaluating or assessing individuals, incorporating more qualitative or mixed methods approaches so that we can better understand the unique experiences of individuals. And as Virginia mentioned earlier as well, the limited research we do have within corrections is mostly focused on prisons, which makes some logical sense because prisons are relatively more stable places to be, and you can do more longitudinal work with those individuals, but we don't have as much on jailed populations. And then we could also increase our research efforts on people who maybe aren't incarcerated themselves, but are nonetheless impacted by the criminal legal system, such as the family members of incarcerated persons, or like I said before, correctional staff, and what we can do to improve their well-being.
We do have a large amount of questions, so I will get started with the first one. How many folks do you see due to inability to adapt to the prison environment due to things like drug use observed, receiving threats of all sorts, having been assaulted, fears due to the gang activity? Many tell me that jail is much easier than prison.
I'm not sure that I quite understand. I mean, everything that you are describing are things that I've heard from people who are incarcerated, fear of, everything. again, as we said at the beginning, jails are in general more chaotic environments, but of course that doesn't mean that prisons are not challenging environments. And in some ways, they're challenging for different reasons. So yeah, I think that's all I can say about that question. But yeah, I mean, everything that you said resonates with me in terms of what I've heard from people who are incarcerated.
Thank you. The next question is, if folks do not request mental health care, how would you know who would meet criteria for this? When folks present for mandated treatment post-release, most deny any problems until after several months. When asked, most do not feel comfortable asking for help due to stigma when it is inside, and then this is maintained once released due to habit, etc. Anyone studying this, just curious. Majority have PTSD related to experiences while incarcerated.
Yeah, I don't know that I have a great answer in terms of a solution to that issue, but as I said before, there are many reasons why people have motivations, both to over-report or under-report symptoms. I completely agree that experiences of trauma, that can also play a very important role. I think that in my experience, the more time that you spend with people and really developing that really therapeutic alliance and relationship, the more likely you are to start getting information from them. I think the motivations are different when people are inside of the correctional institution. You've mentioned mandated treatment. So when people are mandated to treatment in the community, I think the motivations to either over-report or under-report are slightly different. But I think that this issue of engagement is something that every clinician who works with people who are in the legal system struggles with, right? Like, what is that we can do to really engage the population, especially the population who decides that they don't need treatment, and sometimes it's because the treatment they've received in the past has not been helpful to them because they felt discriminated against, because they felt oppressed. And there are many good reasons why that people have not to trust us, honestly, the mental health departments or the correctional departments. And so I think it's a matter of, if you can and have the opportunity to stay connected to that person. The other issue is that sometimes we change providers very quickly, right? And so individuals don't end up working with the same provider for a long period of time. But to me, that is the best way to really develop that relationship and get them to trust you. And then, of course, there are specific interventions like motivational interviewing that have proved to be helpful to engage people. But yeah, it's absolutely a challenge.
I think just to maybe address the part of the question about how, because I think the beginning part of the question was related to essentially how would somebody come to the attention of a provider if they didn't make the request themselves, and if they don't have that motivation or insight, maybe they're not going to make that request and then they'll be overlooked. And I think, unfortunately, at least from my experience working in correctional settings, more on the prison side of things in particular, but I think this would also apply to jails as well, that often the caseloads are so high already that, unfortunately, I think that person would not get mental health services unless they've requested it. So in the Bureau of Prisons, for example, they rely primarily on individuals making requests to see mental health, and then there are guidelines or criteria for when clinicians then have to see that person and address their request. But I think that that's also a good plug for assessment as well, because if people are more routinely assessed on the front end, then maybe some of those needs will be identified. And it's be particularly important, I would think, to use assessment tools that also have response style indicators in them as well. These aren't necessarily foolproof, but things like the MMPI, for example, that might be able to pick up on whether somebody is under or over reporting symptomology, that might be able to inform, how you approach that person or how you talk to them about their symptoms. And then again, just to reiterate Virginia's point, ultimately, I think you're going to have to work to build some of that trust over time, and even acknowledging some of the things that Virginia talked about. Like, I know, what have your experiences been like in treatment, and how can we make this experience different? Or what do you think we can work together on to make this a better a better experience and something that's more helpful for you. So yeah, again, just to kind of again add to that, I think assessment is really important, and unfortunately, this is why we need more mental health professionals working in this area, because those caseloads are so big that if somebody isn't saying, "Hey, I want to see somebody," they may not get seen.
And also, lastly, to that question, I think also doing trainings for the security staff, Department of Corrections, Sheriff's Departments, on how to identify signs and symptoms of mental illness, because they are the ones that are there 24/7, right? The mental health staff is in and out, but they are the ones who are observing that. And those of you who've worked inside of correctional settings can relate to how good officers can really make very good referrals, right? I work with some officers who were just so good at engaging people and saying, "I'm worried. This guy has not showered in 2 weeks, or it's not coming out of their cell, even though they used to come see their families. They're not meeting with their visitors. That's just a change, and then they are the ones who refer the cases. So good training to officers, and just good officers in general, is very important.
A friend has shared with me that when she works with the military, she is often pulled up to disclose confidential conversations with clients. I am wondering if you have had that kind of experience working in the correctional setting. Can you share your experience and how you negotiated it?
I absolutely have had that experience. I think if you've worked in a correctional setting, it's almost impossible not to have had that experience. To me, the way in which these sort of manifest is that the physical environment inside of jails and prisons is often not ideal, and so you might be asked to be talking to someone in like a place where other people are walking around, or the security staff want to be close by because that individual they deem to be at risk of engaging in violence. And so I think that it's hard to negotiate that, but it's developing a relationship with that security department, developing a relationship with that officer, explaining why in that moment it is important that you have a confidential conversation with that individual. And then lastly, if you are unable to, because the reality of the correctional environment is that at times the officer will just say, "For your own safety, I'm not gonna step away." If that is the case, then that you inform the patient client of the limits of confidentiality, right? The fact that you unfortunately are going to have a conversation, and that the officer cannot step away, because sometimes we just talk to them and don't acknowledge that, which is a really important issue. And so I have found that just having the conversation sometimes helps the individual, but it is a real challenge.